welcome all. We continue with our session today, and today's topic for the discussion is acid-base balance. This is very high yield topic for the examination, and always there are SBAs or even in part two there are EMQs on this particular topic. So we will discuss about acid-base balance. There are certain fundamental concepts you are supposed to know. What is the definition of acid and what is the definition of base? Basically, acid is a proton donor. Okay, so it donates the H plus ions. Okay, for example, HCl will be broken down to H plus ion and chloride ion. Okay, and second is H2CO3. Okay, carbonic acid, it will be broken down to H plus ion and bicarbonate. Okay, so that is what is the acid donates. Okay, acid donates the proton, or remember, A for away. Okay, it will give away the proton. Okay, B is borrow. Okay, so it will borrow the proton or acceptor of the proton. A will give away the proton, B will borrow the proton. Okay, so base is the one which accepts the proton. So for example, NH3 will combine with hydrogen ion, will form NH4. Okay, HCO3 bicarbonate will joins with the hydrogen ion, will form carbonic acid, that is H2CO3. Okay, so there are strong acids and there are weak acids. So what is strong acid? Strong acid will completely dissociate. It will have low pKa. Example is a hydrochloric acid. Okay, so it dissociates completely. That is a strong acid and it will have low pKa. While weak acid will partially dissociate and it will have high pKa. Okay, example is a H2CO3. Okay, carbonic acid. Okay, so what exactly the pH is? pH is the negative logarithm of hydrogen ion concentration. Remember, pH is negative logarithm of hydrogen ion concentration. So how it is written? pH equal to negative log of H plus ions. Okay, pH equal to negative log of H plus ions. Okay, or if you want to write, hydrogen ions will be equal to 10 to the power of minus pH. Okay, that is the way it is written. Okay, so what are the values which you should know? Normal pH. What is the body pH normal? 7.4 is the normal value, but it has got a range. That is 7.35 to 7.45. You have to know this because all the questions, these values are important. And hydrogen ion concentration is a 40 nanomole per liter. Okay, so when it is less than 7.35, that is if it is a 7.32, 7.34, we say it is a acidic pH. When it is 7.46, 7.48, we will label this as a alkalosis. Okay, so alkaline pH is there. So normal value is 7.4, range is 7.35 to 7.45. That is the normal range. Okay, below this range is the acidic and above this range is the alkalosis. So when the pH decreases, hydrogen ions will increase. That is the acidosis. When the pH is increased, the hydrogen ions will be reduced, and that is the condition of alkalosis. Okay, so when the pH is less than 7.35, it is acidosis. Less than 7.2 is a severe acidosis. Less than 7 usually incompatible with the life. More than 7.45 is alkalosis, and more than 7.6 is usually incompatible with life. Okay, now the concept of pKa. Okay, so what is that pKa? pKa equal to pH at which 50% acid is dissociated. Okay, so it is that pH at which acid is dissociated 50%. Okay, that means the acid will be 50% and the salt will be 50%. Okay, so at pH equal to pKa, when salt is to acid is 1:1. So when the salt is to acid ratio is 1:1, pH will be equal to pKa. Okay, so it is because at this pH, the acid is dissociated 50%. So 50% will be in a base form, 50% will be in a acid form. Okay, so base is equal to acid. That is the salt will be equal to acid. That is 1:1 will be there. So at that level, pH will become a pKa. Okay, so there is a Henderson Henderson-Hasselbalch equation. Okay, so this equation may not be asked, but the concept you should know, because they may ask you Henderson-Hasselbalch equation maybe is related to what. Okay, so this Henderson-Hasselbalch equation tells about the relation between the pH and pKa. So what does it tell? pH equal to pKa plus log of bicarbonate divided by PCO2 into 0.03, or in a simple form, pH equal to pKa plus log of salt upon acid. Okay, even if you remember this salt upon acid, that is fine. So pH equal to pKa plus log of salt upon acid. So salt is carbonate and acid is PCO2. Okay, so when acid is equal to base, that time pH equal to pK. We have mentioned 50% acid, 50% base. That time pH equal to pK. Okay, but if the salt is 10 times of the acid, so salt will be 10 times of the acid. So this ratio salt upon acid will be 10:1. Then 10:1, this ratio is there. That means log of 10. Log of 10 is 1. So pH equal to pK plus 1, because log of 10 upon 1, that is log of 10 to the base 10 is 1. Okay, so it will be pH will be pKa plus 1. And if salt is to acid ratio is 1:10, now if the salt is to acid ratio is 1:10, at that time pH will be pH equal to pK minus 1. Okay, so it depends upon this salt is to acid ratio. So remember this Henderson-Hasselbalch equation is related to the acid base balance, where pH equal to pKa plus log of salt upon acid. Okay, and when salt is 10 times and acid is 1 times, it will be log of 10 to the base 10, which is equal 1. So pH equal to pKa plus 1 when this ratio is 10. Okay, but if this is opposite, then pH equal to pKa minus 1. Okay, so what are the buffers, okay, in the body? Okay, this is an important concept which you should know. Buffers in the body. Okay, buffers will resist the sudden changes in the pH when acid or alkali is added. Okay, so the body may have the condition of acidosis, alkalosis, depending upon the situation, clinical situation, but that will be, body will always try to maintain this pH because of this buffer system. So what are the buffer systems which are available? First is a bicarbonate buffer, that is H2CO3 and carbonate, that is SCO3. Then phosphate buffer, H2PO4 and HPO, hydrogen diphosphate. Okay, hydrogen dihydrogen phosphate and hydrogen diphosphate. Then protein, plasma proteins are there. Hemoglobin, that is hemoglobin and proteinated hemoglobin. Okay, so these are the buffer systems which are there. Remember, bicarbonate buffer, phosphate buffer, protein buffer, and hemoglobin. These are the 4 buffer systems which are available. Okay. So most important extracellular buffer is bicarbonate buffer. This also you should remember, which is the most important extracellular buffer. It is the bicarbonate buffer. Which is the most important intracellular buffer? It is the phosphate buffer. And major protein buffer is the hemoglobin. Okay. Major protein buffer is the hemoglobin buffer. Extracellular is bicarbonate, intracellular is a phosphate, and major protein buffer is a hemoglobin. Okay. Now, what is the body's defense against the acid load? When the acid levels are increased, how the body will respond? Okay. When the acid load is increased, there are 3 lines of defense which are coming into the action. Okay. The first is the blood buffers, which will come into action within seconds. Second, lung buffer will come into action within minutes, and third is a kidney buffer, which will come into action in hours to days. Okay, it will take long time for the kidney buffer to come into the action. That will take hours to days. Okay, so you remember the body defense against acid load is BLK. Okay, B blood buffers, L lung, and K for kidney. Okay, so the BLK is the buffer system. Blood buffers will come into action in seconds, lungs will take minutes, and kidneys will take hours to days. Okay, it takes a long time for the. So this BLK is the mnemonic you should remember. So blood buffers, lungs, and kidneys. Okay. The most important buffer is a bicarbonate buffer, you should know. So this bicarbonate buffer, that is the carbon dioxide will combine with hydrogen H2O, that is water, and will form with the in presence of carbonic anhydrase enzyme, and will form H2CO3. This H2CO3 will be broken into H plus and HCO3 minus, that is bicarbonates. These equations will not be asked. Okay, but the bicarbonate levels you are supposed to know, PaCO2 levels you are supposed to know. This is just for the understanding purpose. Okay, so CO2 plus H2O in presence of carbonic anhydrase will form H2CO3, which will be further broken down into H plus and HCO3 minus. And this is a bidirectional. Depending upon the pH, if the H plus ions are increased, it will go in this direction. It will form H2CO3. If the H2CO3 will be broken down to CO2 plus H2O, CO2 will be removed from the lungs. Okay. And if the hydrogen ions are less, in that particular CO2 plus H2 will combine, will form H2CO3 in presence of carbonic acid. This will broken down to H plus and HCO3 minus, and it will maintain the hydrogen ion levels and maintaining the pH. Okay, so this is the bicarbonate buffer is the most important buffer. Okay, so what is the bicarbonate level? Normal, it is 24. Remember always, because scenario will be having this particular value. Bicarbonate buffer is 24. PaCO2 value is 40 millimeters of mercury. Carbonic acid is 1.2 millimole, and pKa is 6.1. Okay, these are the important values. Bicarbonate 24, PaCO2 40, carbonic acid 1.2. Okay, they may ask you the ratio of bicarbonate to carbonic acid, that is 2.24 divided by 1.2. So bicarbonate to carbonic acid ratio 24 to 1.2, that is 20:1. Okay, so bicarbonate to carbonic acid ratio is 24 to 1.2. So this is also one of the commonest being. So normal blood pH exists because of the bicarbonate to carbonic acid ratio, which is maintained at 20:1 level. We always have an alkali reserve. Okay, there is always alkali reserve. This alkali reserve is mainly because of the bicarbonate. Okay, so it is the amount of bicarbonate which is available to neutralize the acid. Okay, so this bicarbonate is the alkali reserve, and the level you should remember is 22 to 26 millimoles per liter. Average is 24 millimoles per liter. Okay, this bicarbonate level you are supposed to know, it is 24 millimoles per liter. Okay, now what happens? Okay, we have mentioned that these are the buffer systems which are available. Lung buffer is there, blood buffers are there, kidney buffers are there. So what is the respiratory regulation? Okay, so the first buffer which comes in action in seconds is the blood buffers. Second line of defense is the respiratory regulation. It will act in minutes. Okay, how does it act? So when there is a acidosis, the pH will be reduced. If the pH is reduced, there will be hyperventilation. Hyperventilation, because of which CO2 will be washed out and pH will be raised. Okay, so when the acidosis is there, pH will be reduced, there will be hyperventilation, CO2 will be washed out. Okay, so there will be reduction in the CO2 level and pH will be increased. In alkalosis, what happens? The respiratory compensation, the pH is an increase in this particular case, that leads to the hypoventilation, that leads to increase PCO2, that leads to the reduced pH. Okay, so that is how the respiratory compensation comes into the picture. So for example, if you have a case of diabetic ketoacidosis, there will be a small respiration, and that will lead to the respiratory compensation. Okay, now another buffer is a renal regulation. Okay, this is a strong but it takes time for the kidneys. It takes time to come into the action. So that is the third line of defense, but slow but most powerful. It is slow but most powerful. Okay, it begins hours. Okay, effect is seen in 3 to 4 days, and kidneys will dump the acid but save the base. So what exactly it does? It will dump the acid but save the base. Okay, so what are the mechanisms by which the kidney acts? It will secrete the hydrogen ions. So there will be acid excretion. That is one mechanism. Second, it will reabsorb the bicarbonates. Okay, so that will be the base conservation. Second, it will form the titrable acid formation is there. So net acid loss is there. Okay, so it will form the titrable acid formation. Then NH4 is excreted. That is the major chronic adaptation is there. Okay, these are the four ways by which the kidneys will act. And the enzyme involved in the kidney is a carbonic anhydrase. And this carbonic anhydrase is inhibited by the acetazolamide. Okay, so H2O plus CO2. This reaction is happening in presence of carbonic anhydrase. And this is inhibited by the acetazolamide. Okay. Now, what is the relationship between the pH and potassium? That also you should know. What happens if there is a acidosis? What happens if there is a alkalosis? Okay. If there is a acidosis, that will lead to the hyperkalemia. Okay. So H plus enters the cells and potassium will leave the cells. When there is a acidosis, obviously H ions are more, so they will enter into the cell and potassium will leave outside the cell. Okay, so in acidosis there is a hyperkalemia. In alkalosis there is a hypokalemia. H plus will leave the cells and potassium will enter the cells. Okay, except renal tubular acidosis, when there is a hypokalemia. Okay, so most of the acidosis you will have the hyperkalemia, except renal tubular acidosis where there is a hypokalemia. So acidosis will lead to the hyperkalemia, alkalosis will lead to the hypokalemia, except in renal tubular acidosis there is a hypokalemia. Okay, these values you are supposed to know. Okay, pH is normal, what we have seen 7.4, range is 7.35 to 7.45. PaCO2 is 35 to 40. Remember 40 plus minus 5. Okay, 35 to 45 is PaCO2 level. Bicarbonate levels also you are supposed to know, that is 24. Okay, so 22 to 26 is the level, 24 plus minus 2. PaCO2 80 to 100 millimeters of mercury, sodium 136 to 145, potassium 3.5 to 5 or sometimes 5.5, some books have given, and chlorides is 96 to 106. These all levels you are supposed to know, because the scenario will mention these levels, and from which you have to interpret whether it is acidosis or whether it is alkalosis, whether it is respiratory or metabolic. Now from here onwards, the exam related questions will be there. Okay, so acid base disorders, how will you identify?
Thank you,
So
thank you, sir.
acid base disorder. Okay, so what happens in metabolic acidosis? pH is reduced and bicarbonates are reduced. In alkalosis, pH is increased, bicarb are increased. Okay, in respiratory acidosis, pH is reduced, PaCO2 is increased. In respiratory alkalosis, pH is increased, PaCO2 is reduced. Just remember, when we are dealing with acidosis, look at the bicarb. Okay, when we are dealing with metabolic, look at the bicarb. When we are dealing with respiratory, look at the CO2. Okay, and in metabolic, this thing, pH and the bicarbonates will go together. Okay, if it is a acidosis, pH will be reduced, but if it is a metabolic, pH will also be reduced and bicarb will also be reduced. Okay, so metabolic goes with bicarb, respiratory goes with the PaCO2. Then acidosis, there will be reduction in the pH. Simultaneously, there will be reduction in the bicarb. Okay, it is exactly opposite happens in the respiratory. Respiratory goes along with CO2, but it has got an inverse relation with the pH. That means respiratory acidosis, what will happen to the pH? It will be reduced, but PaCO2 will be increased. So when we are dealing with the respiratory, think about CO2. Think, are we dealing with acidosis or alkalosis? If it is acidosis, that means pH will be reduced. At that time, the CO2 will be increased. If there is alkalosis, respiratory alkalosis, that means pH will be increased, but bicarbonate PaCO2 will be reduced. Okay. But if it is metabolic acidosis, it goes in the same direction. Okay. But metabolic will deal with bicarbonates, respiratory will deal with PaCO2. Okay. So it goes in the same direction with metabolic, it goes in opposite direction with the respiratory. The mnemonic is Rome, respiratory opposite, metabolic equal. Okay. respiratory opposite, metabolic equal, pH is reduced, PaCO2 is increased, respiratory opposite, pH is increased, CO2 is reduced. Okay, so respiratory goes in opposite direction. Respiratory acidosis, respiratory alkalosis, but this goes in the opposite direction. Arrows will go in opposite direction. Now metabolic is equal, pH is reduced, bicarb will also be reduced. pH is increased, bicarb will also increase. Okay, so look at these levels while interpreting your question. Okay, because values will be given to you. They will give you the pH of 7.22 is there. That means it is an acidic pH. But at this pH, what is happening to CO2 and what is happening to the bicarb that you are supposed to know? At the same time, another concept of anion gap, which we will be covering, that also you are supposed to know. So first thing, look at the pH, what is happening. Then look at the bicarbonates, what is happening. Then look at the PCO2, what is happening. Okay. Then conclude, what are you dealing with? What is the primary disorder? Whether it is a metabolic or whether it is a respiratory. Okay. Acidosis or alkalosis, that you will come to know by looking at the pH. Okay. But whether it is respiratory or metabolic, depending upon these changes, you will come to know whether they are going in the same direction or whether they are going in opposite direction. Okay. So now let us see. Now, what happens when there is a acidosis or whether there is a alkalosis? There are some compensatory mechanisms which are coming into the action. Okay, so if it is a metabolic acidosis, the compensation is by CO2. Okay, okay. While interpreting what we said, metabolic, look at the bicarb. Respiratory, look at the CO2. That is what we have said. But when there is a compensation, because any acidosis which is there, that body will try to compensate. Any alkalosis, body will try to maintain the pH. But that compensation in cases of metabolic will happen by changes in the PaCO2 in cases of metabolic acidosis. We have seen in metabolic acidosis, pH will be reduced and bicarb level will also be reduced. Okay. But the compensation is also by PaCO2, it will be reduced. Okay. So all three will go in the same direction. In metabolic alkalosis, what is going to happen? The bicarb will be increased, pH will be increased, and PaCO2 will also be increased because compensation is by PaCO2 in cases of metabolic acidosis. In respiratory, the compensation is by bicarb. Okay. So in respiratory acidosis, pH is reduced and what we say, if pH is reduced, PCO2 will be increased, bicarb will also be increased as a compensation. Okay. In respiratory alkalosis, pH is increased. Now this PaCO2 will go in the opposite direction and bicarb will also go in the opposite direction. So compensation happens by bicarbonates. In respiratory, compensation happens by PaCO2 in metabolic. Okay. Now the concept of the anion gap. Now this anion gap is nothing but the total cation minus total anions. That is the positive ions minus the negative ions. You have to do the subtraction. Okay. Sodium and potassium, these are cations. Anions are chlorides and bicarbs. So if you are given the value of sodium, potassium, chloride and bicarb, you just have to add all positive, that is sodium, potassium together and chloride and bicarb together, and then you have to subtract from positive from the negative. Okay. So, but practically this potassium is not taken into account and only sodium minus all, because sodium is the major. Okay. Sodium is the maximum amount. So sodium minus, this is also a way of mentioning anion gap. Sodium minus all negative ions. Negative ions are chlorides and bicarb. Okay. So normal value you are supposed to know 12 plus minus 2. So remember 12 value plus minus 2 is the normal anion gap. Okay. So without potassium, most common is 8 to 12 milliequivalents per liter, but most of the time potassium is not taken into account. So with potassium, so without potassium, this is the most common, and with potassium, it is 12 to 16. Okay. So when you have got a nothing is mentioned, then it will be without potassium. Okay, so 8 to 12, this you are supposed to remember. Okay, so definition of anion gap more than high anion gap. Okay, it is called as HAG. Okay, and this is leg. Okay, LAG. High anion gap more than 12 is called as high anion gap. When potassium is not included, this indicates the presence of unmeasured anions in the blood, that is lactate, ketones, toxins, etc. And low anion gaps. Okay, low anion gap, when anion gap is less than 8 milliequivalents per liter without potassium, low anion gap is relatively uncommon. Okay, so for high anion gap metabolic acidosis, also called as HAGMA. Okay, and this normal anion gap metabolic acid is called as NAGMA. Okay, so HAGMA examples are gold mark is the mnemonic, glycols, oxoproline, L-lactate, D-lactate, menthol, aspirin, renal failure, and ketoacidosis. Remember few things: lactate, glycol, menthol, aspirin. You can remember. So in these cases, ketoacidosis you will remember, renal failure. In most of the cases, you will have a high anion gap metabolic, and this is when only when you have metabolic acidosis you look into this high anion gap or the normal anion gap. Low anion gap is not actually it is not very common. So whether anion gap is high or whether there is a normal anion gap, that is NAGMA, NAGMA or HAGMA. Okay, what situation you are dealing with? Okay, high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So high anion gap, there will be metabolic acidosis, you will be able to understand. But whether it is a high anion gap, because if you are given the anion gap or if you are given the values of the sodium potassium, then you need to calculate the anion gap and interpret whether it is a high anion gap or low anion gap. Okay, they may give you all the values. Generally for part 1 they may not ask you to calculate this anion gap, then that may be a separate question calculation, but not the interpretation of the condition along with the anion gap. It may not be there. Okay, so high anion gap metabolic acidosis is seen with glycols, oxoprolyl, L-lactate, D-lactate, menthol, aspirin, renal failure, and ketoacidosis. Second is a normal anion gap acidosis, that is hyperchloremic. Okay, so this hyperchloremic, that is normal anion gap acidosis, is seen with hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, ureteric diversion, and pancreatic fistula. Okay, so bowel related condition and kidney related condition and drugs you remember. When there is a hyperalimentation, acetazolamide, again drug which acts on the kidneys, renal tubular acidosis related to the kidneys, diarrhea related to the GIT, ureteric diversion related to the kidney, pancreatic fistula related to GIT. So these conditions, this is just I'm making it little simplified so that you can understand. Okay, mnemonic is a hard up. Okay, hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, ureteric diversion, pancreatic fistula. These are the conditions where the anion gap will be normal. Okay, it is a normal anion gap acidosis, that is NAGMA. Okay, so from examination point of view, what you should remember, diabetic ketoacidosis, it is a high anion gap metabolic acidosis. If there is a severe diarrhea, that will lead to the metabolic alkalosis, but normal anion gap will be there. Okay, if there is a vomiting, metabolic alkalosis. Okay, remember, anything which goes out of the upper GIT will lead to the alkalosis. From lower GIT, diarrhea, it will lead to the acidosis. Okay, because acid goes out in the vomiting, alkali will remain. Okay, so if it is a case of hyperemesis gravidarum, you will get metabolic alkalosis. If it is a case of severe diarrhea, you will get metabolic acidosis, but it is a normal anion gap with severe diarrhea. Okay, COPD, respiratory acidosis, hyperventilation, respiratory alkalosis. Okay, early salicylate poisoning, respiratory alkalosis, late salicylate poisoning, metabolic acidosis, and renal failure, high anion gap metabolic acidosis. Okay, renal failure is a high anion gap metabolic acidosis. Okay, so when you are interpreting data interpretation questions on this acid base balance, first look at the pH and identify whether it is acidosis or alkalosis. If pH is reduced, that is less than 7.35, you are dealing with acidosis. If pH is increased more than 7.45, that means you are dealing with alkalosis. So only options with alkalosis or acidosis you will look into it. Okay. Then look at the PaCO2 value, look at the HCO3 value, in which directions they are going, whether they are increased or whether they are decreased, and what is their relation with respect to the pH. Okay. Then you will decide the primary disorder. Then you will check for the compensation, calculate the anion gap if metabolic acidosis. Okay. Primary disorder, like in the first table, what we have seen, you have metabolic, you will look at the CO2. Okay. You have respiratory here. You have metabolic, you will look at the bicarb. You have respiratory, you will look at PaCO2. This is the primary disorder. Okay. Compensation, you will look metabolic, you will look for bicarb CO2 compensation. Respiratory, you will look for bicarb compensation. Okay. So that is the thing which you are supposed to look for. And then you will calculate the anion gap. Okay. So the steps in rapid ABG interpretation. Step 1, look at the pH, whether it is acidosis or alkalosis. Step 2, look at the PaCO2, look at the bicarb level, decide primary disorder, then check for the compensation, then calculate the anion gap if it is a metabolic acidosis. Okay. So from examination point of view, these are the points you will remember. Normal pH is 7.4. Normal bicarb is 24 millimoles per liter. Normal PaCO2 is 40 millimeters of mercury. Important SBA bicarbonate to carbonic acid ratio is 20:1. Okay. Most important extracellular buffer is bicarbonate. Most important intracellular buffer is phosphate. Carbonic anhydrous inhibitor is acetazolamide. Then diabetic ketoacidosis is associated with small respiration. Acidosis leads to the hyperkalemia. Vomiting will lead to the metabolic alkalosis. Diarrhea is a normal anion gap metabolic acidosis. Renal failure, high anion gap metabolic acidosis will be there. Okay. So we finished the topic here. We have few concepts, doctor, questions, doctor. So who wants to read the questions?
Yes, sir.
Yeah, please go through.
A medical student is asked about the definition of acid during the physiology viva. Which one of the following best defines the acid? A substance that accepts the proton, B, substance that donates the proton, C, a substance that releases hydroxyl ion, D, a substance that binds the chloride ion, and E, a substance that increases pH. Sir, answer is B, the substance that donates proton.
Correct. Okay. So away from proton, acid away, give away. Okay. A substance that donates proton. Okay. Acid proton donor, base is a proton acceptor. Okay. Next.
Henderson-Hasselbalch equation is most useful clinically for assessing A. Renal plasma flow, B. Acid-base balance, C. glomerular filtration rate, D. Osmolarity, and E. Cardiac output. Sir, answer is B. Acid-base balance.
Correct. Acid base balance. So Henderson-Hasselbalch equation relates to the pH to the bicarb into bicarb to carbonic acid ratio. Okay. So pH equal to pKa plus log of carbonates upon bicarb carbonic acid. Next.
Which buffer system contributes the highest buffering capacity in extracellular fluid? A. Phosphate buffer, B. Hemoglobin buffer, C. Protein buffer, D. Bicarbonate buffer, E. Ammonia buffer. So extracellular, it is the major is the bicarbonate.
Bicarbonate
B.
buffer, right. So the bicarbonate buffer acid system accounts for approximately 65% of the plasma buffering capacity. Next.
A woman with diabetic ketoacidosis present to emergency department with electrolyte abnormality is most likely before treatment. A. Hypercalcemia, B. Hypokalemia, C. Hyperkalemia, D. Hypernatremia, and E. Hypermagnesemia. Sir, acidosis is hyperkalemia.
Correct. So option C,
C.
hyperkalemia. So in
Hyperkalemia.
metabolic acidosis, H plus will enter, potassium will leave, resulting in hyperkalemia. Next.
Hyperkalemia. ABG result, pH is 7.22, then PaCO2 is 30 mmHg and HCO3 is 14 millimole per liter. What is most likely diagnosis? A. Uncompensated metabolic acidosis, B. Partially compensated metabolic acidosis, C. Fully compensated metabolic acidosis, D. Respiratory alkalosis, and E. Mixed alkalosis. So pH is less, so it is acidosis, first of all.
So only three options are there with us. Okay, 1, 2, and 3 now. Okay, now so PaCO2
pH,
normal range is 40 millimeters of mercury. It is not increased. Okay, so PaCO2 is not
it is
increased. Bicarb level is normal. Bicarb is how much?
22, 24. So
24. It is
bicarb is
reduced.
decreased.
Okay.
PaCO2 is also decreased.
Yeah.
Bicarb is also decreased and pH is decreased.
So we are dealing
So
with
metabolic
metabolic
compensate.
acidosis.
So it is compensated. It is fully compensated metabolic acidosis.
No, it will be partially compensated. If it is a fully compensated, the pH will come to the normal. So pH is still
Okay.
low. Okay. So it is a partially compensated metabolic acidosis. Okay. Partially compensated metabolic acidosis, pH is reduced, there is acidosis. Bicarb is reduced, metabolic cause. Okay, PaCO2 is reduced, that is respiratory compensation. Since pH is still abnormal, that means there is a partial compensation. Okay, you got it.
No.
All these three
Yes,
are
sir. Yes.
reduced. Okay, but still pH is abnormal. That is why it is not full compensation. Okay.
Okay, sir.
Next.
So pH is 7.52, PaCO2 is 28, and HCO3 is 23. So pH is increased. This is alkalosis. Then PaCO2 is 28, means it is also increased.
PaCO2, what's happening? Normal is 40 millimeters of mercury. 40.
40. So it is decreased.
Yeah.
And HCO3 is, so 23 is,
It is normal. Bicarb is almost normal actually. 24 is
so
the
it is
level.
respiratory.
Yes.
So it is respiratory alkalosis.
Yes, because pH is increased and PaCO2 is low. Okay. So it will be
Okay,
respiratory
sir.
alkalosis. Okay. So high pH is
Yes, sir.
alkalosis and low PaCO2 respiratory origin. Okay. Rome, respiratory opposite,
Oh.
metabolic equal. Okay. And bicarb are normal. Okay. So it is acute or uncompensated. Next.
A patient has the following biochemistry. Sodium is 140, potassium is 4, chloride is 100, HCO3 is 16. Calculate the anion gap. Sir, we'll add the sodium and potassium and subtract the chloride and
Yeah.
HCO.
So 140 plus 4, that is 144 will be there, and divide minus 100 plus 16, that is 116. Okay. 144 minus 116. Okay. So it will be, I think,
28. 28,
20.
sir.
Yeah, 28. It will be 28. Okay. So anion gap 28. Is it increased or decreased? This anion gap.
It is increased, sir.
Yeah.
Anion gap.
High anion gap metabolic. Okay. HAGMA examples you should know. NAGMA examples you are supposed to know. Next.
A 30-year-old woman present with the profuse diarrhea for 3 days. Which acid-base abnormality is most likely? A high anion gap metabolic acidosis, normal anion gap metabolic acidosis, C respiratory alkalosis, D metabolic alkalosis, and E is respiratory acidosis. Sir, vomiting is metabolic alkalosis.
And diarrhea is
Diarrhea is metabolic acidosis.
correct. So option only two are remaining now, A and B. Okay. Now it is HAGMA or it is NAGMA. Which one is there?
Option B, sir.
Sir, it is
It is B. Normal anion gap metabolic acidosis. Okay, normal anion gap.
yes.
It is a normal anion gap. Here, normal anion gap metabolic acidosis. Diarrhea causes direct loss of bicarbonate, resulting in hyperchloremic. That is
Hyper.
normal anion gap metabolic acidosis. Dr. Sansi, you want to go ahead with these questions? Next.
Yes, sir. A woman with hyperemesis gravidarum has persistent vomiting for 1 week. Which acid-base disturbance is expected? Metabolic acidosis, respiratory acidosis, respiratory alkalosis, metabolic alkalosis, respiratory alkalosis, high anion gap acidosis. So it is metabolic alkalosis, option C.
Yeah, it is a vomiting. Acid goes out, so remains alkali in the body. So loss of gastric HCl causes loss of H plus, loss of chloride, hypochloremic metabolic alkalosis. Next.
Data interpretation, pH is 7.35, which is normal. PaCO2 is 60 mm of Hg, which is increased. Bicarbonate is 36 millimole per liter, which is also increased. So this is acute respiratory acidosis, fully compensated respiratory acidosis, metabolic alkalosis, mixed acidosis, respiratory alkalosis. PaCO2 is increased. So this is respiratory acidosis, but pH is normal. So sir, option B, fully compensated respiratory acid.
pH has come to normal, but still there is alteration in the PaCO2 and SCO3. That means initially it was an acidotic condition. The pH has brought to the normal by the compensatory mechanism. So it becomes fully compensated respiratory acidosis. Okay.
Yes, sir.
Because these two are increased. Okay.
Yes.
So fully compensated respiratory acidosis, pH is normal, PaCO2 is elevated, bicarb is also elevated. Normal pH with appropriate renal compensation indicates fully compensated respiratory acidosis such as COPD. Okay, next.
Which one of the following condition typically causes a high anion gap metabolic acidosis? Vomiting, diarrhea, renal tubular acidosis, diabetic ketoacidosis, nasogastric suction. Sir, option D, diabetic ketoacidosis.
Yes, diabetic ketoacidosis is a metabolic acidosis with high anion gap. Okay. So causes of HAGMA include diabetic ketoacidosis, lactic acidosis, renal failure, methanol poisoning, and salicylate poisoning. Okay. Next.
A critically ill patient has the following result. pH is 7.1, which is decreased. PaCO2 is 18 mm of Hg. It is also decreased. Bicarbonate is 8 millimole per liter. It is also decreased. Lactate is 8 millimole per liter. What is the most likely diagnosis? Is acidosis. PaCO2 is decreased. Bicarbonate. Metabolic acidosis. Decreased. Compensatory. Lactic acidosis with respiratory
With the
compensation.
respiratory compensation.
Correct. Because lactate levels are also increased and PaCO2 is reduced. So respiratory compensation has come into the action and pH is low. That means we are dealing with acidosis. So it is a lactic acidosis with respiratory compensation. Okay. So lactic acidosis with respiratory compensation. Okay. So few take home message: vomiting is a metabolic alkalosis, diarrhea, normal anion gap metabolic acidosis, diabetic ketoacidosis, high anion gap metabolic acidosis, lactic acidosis is also high anion gap metabolic acidosis, COPD, respiratory acidosis, hyperventilation, respiratory alkalosis, early salicylate poisoning, respiratory alkalosis, late salicylate poisoning, metabolic acidosis, renal failure is a high anion gap metabolic acidosis, and hyperemesis gravidarum metabolic alkalosis. Okay. So values from the examination point of view, you should remember normal pH 7.4 plus minus 0.05, that is 7.35 to 7.45. Normal PaCO2 is 40 plus minus 5, 35 to 45 millimeters of mercury. Normal bicarb level is 24 plus minus 2, 22 to 26 millimoles per liter. Normal anion gap is 12 plus minus 2 millimoles per liter. Anion gap is sodium plus potassium minus chloride plus bicarb. Okay. Rome rule, you should know, respiratory goes in opposite, metabolic is goes in equal. Acidosis leads to the hyperkalemia and alkalosis leads to the hypokalemia. That finishes the topic of acid base balance. Thank you.